Hello, everyone, and welcome to one of Cover LLC's webinars. This is our Cover Age Aging Solution series. Today, I am so pleased to bring to you Branka from the Benjamin Rose Institute about care consulting and caregiver consulting. Before we get started, if you have any questions, please submit them in the Q&A, and I will ask Branka when we get to spots for questions. Branka, please give the rest of your introduction and feel free to dive in.
Okay, thank you everybody, and thank you for joining us either this afternoon or morning, depending where you are in the United States. As Marie said, I will be presenting today on BRI Care Consultation, a little bit about caregiver needs and the evidence-based program BRI Care Consultation. So I am the BRI Care Consultation Program Manager at the Benjamin Rose Institute on Aging. So my role is to inform about the program, to create awareness around it, market it, and really help organizations implement the program. So everything from identifying appropriate staff, knowing what the appropriate clients are for the program, training and support, and especially utilizing the care consultation information system that goes along with delivering the program, and it helps guide all the evidence-based components, which I will jump into. Before I begin talking about the program, I'm going to talk a little bit about, like I said, care. Well, first let me tell you about Benjamin Rose Institute on Aging for those of you that are new to knowing about the organization. So we are an over 110-year-old Cleveland-based nonprofit, and our mission has always been support caregivers and empower people to age well. And we do this by conducting research, delivering consumer responsive services, and also engaging in advocacy. So we have a wide array of services at Benjamin Rose. We have senior centers, we have behavioral health services, a senior companion program. We also provide financial wellness programming, and so it just spans a broad range of different types of services that help older adults remain in their homes, as well as supporting caregivers and taking care of themselves so they could take better care of their loved ones. We have a research institute. We conduct a variety of different research, everything from you know caregiving, dementia, to we've conducted nursing home satisfaction type research, as well as elder abuse, and so we have a wide array of research that we do, as well as evaluation. We foster engagement with public policies that impact the field of aging. So now I'll jump into talking a little bit about caregivers and giving you a background of why it's so important to consider having caregiver support programs, especially ones that help yield the results that you're looking for and that your families are looking for, helping with their emotional health, and helping their loved one remain at home and so forth. But it's first important to understand, who is a typical family caregiver. So much of this information was abstracted from the most recent AARP and National Alliance for Caregiving material, the report that they frequently publish. And so here we have the majority are children. So about 50% of caregivers are children, followed by spouse, then grandchild, sibling, as well as in-laws, and then parent and other. And parent for those, especially with special needs. So we have, that represented here as well. And so again, talking a little bit further about who is a typical caregiver. So nearly 2/3 are women. About half are married. The majority are between the ages of 50 and 64. So that touches upon majority being the baby boomer population, but followed very closely by the other generations as well. So those in Generation X and millennials, those are growing as well. Nearly 6 in 10 caregivers are currently employed, 61%. And so it's really important to, again, provide, care and support to those caregivers that are juggling part-time, full-time jobs, as well as caring for their parents or spouses or even children with special needs. Caregivers with the heaviest caregiving responsibilities are sometimes less likely to be employed. And so there was research conducted on those that really do provide intensive care that are not likely to be employed because they have um, because they're taking care of their loved ones. So, um, what do caregivers do? Well, about 60% of caregivers help the person they're caring for with activities of daily living. And so we have here the majority of caregivers help with getting their loved one in and out of bed, followed by getting dressed, bathing and showering, feeding, and so forth. So we have here that caregivers spend about 24 hours per week providing care on average. And so, as you can see, these are definitely for those that do require a little bit more assistance, and 24 hours is quite a bit of time, especially for those caregivers that are employed. And then in terms of independent activities for daily living, so caregivers help with an average of 4.4, about 4.5 of these. Transportation is a big one. Transportation services are sometimes hard to find in some communities, especially rural communities. And so they're dependent on their family and friend caregivers to provide them with transportation, as well as grocery shopping, because that also involves transportation to get to and from and to get the items, to the home and to put them away at times. Then we have housework, preparing meals, managing finances, giving medications, pills and injections, and arranging services. So you can see here that these percentages are pretty high, which is why it's important to assist with linking caregivers to these services and to help manage their lives and reduce levels of strain. So how does providing care affect caregivers? So here we have some diagrams. Nearly 1 in 4 caregivers stated that it is difficult to take care of their own health, so 23%. So what are they doing to help them address their health concerns, and who's helping the caregiver? Um, so it's important, even the ones we have here, 23% agree, but we also have ones that fell in the middle, which means that, they still have some concerns. They're just not as high as some of the ones that either agreed or strongly agreed to this statement. And then nearly 1 in 4 caregivers stated that it is difficult to take care of one's, then that's a duplicate here, so I have to fix that, to take care of their physically strained. So they responded as having a high level of physical strain, and that's actually at 17%. In terms of emotional health here, we have nearly 4 in 10 caregivers consider their caregiver situation to be highly stressful, while about 3 in 10 report moderate emotional stress. So again, having someone that caregivers can connect to help manage their care situation is very important to help them to help prevent burnout that they might be experiencing or on the verge of experiencing. And about 1 in 5 of caregivers do report they feel alone and isolated. So it's again important that they have someone to connect with, and for that professional to help them connect with other um, services that could help alleviate their isolation, or give them tips on how to help cope with that and how to, get out, and so they're not as isolated. So what do caregivers report in terms of them needing help? So here we have some items that caregivers reported that it's most important for them to keep the care recipient, the person they're caring for, safe at home. So safety is number one on their mind. Also, managing emotional and physical stress. It's quite stressful if their loved one is if there's indicators or feelings of that person being unsafe. Obviously, that comes with a lot of emotional and physical stress. And then just trying to work through paperwork and eligibility for services, making those phone calls and filling out that paperwork could get pretty intense and time consuming. Then followed by activities that caregivers can do with the recipient. So, especially if the care recipient has cognitive impairment or physical disability, how can they still spend quality time with their loved one? What types of adapted activities can they do? And then you have others here that are kind of falling a little bit lower on the spectrum, making end of life decisions, finances, thinking about placement. And one I thought that was interesting, the 12% is using technology to care for recipients. So that one is a newer one from previous ARP reports that I noticed. It's getting a little bit higher there, especially with things that have gone on in the past year and a half or so. Then there's challenging behaviors. That's actually a big one when it comes to BRI care consultation and what care consultants work with clients on is how to manage those challenging behaviors related to dementia or other psychological type diagnoses. And then we have, finding materials that they could understand. That also is a little bit lower than I thought it would be, but it depends to, how they obtain their survey recipients. So, this table here just outlines some of the things that that clients within the BRI Care Consultation program have stated when they first started working with a care consultant. So, um, not knowing what services fit their needs, having a hard time helping my loved one understanding care and accepting help, loved one acting different. What's going on? What should they do? It's catching them off guard. They don't know how to respond or help them. Having a hard time getting everything done. Things are becoming really stressful. Just receiving a diagnosis such as dementia, not knowing what it means and what to do with it. Safety concerns, which were pretty much on top of that list from ARP. And then also families disagreeing about care and next steps. So, how great would it be to have somebody there, a professional that could meet with them and talk about the differences in opinion and um, come to a level of agreement among everybody. I added the slide here because what I just presented was very much, the emotional stress, the physical stress. What do people need to help, themselves and their loved ones? But, a lot of caregivers, 51% according to ARP, do experience a sense of purpose and feel their role as a caregiver gives them meaning in their life. And so, why programs such as BRI Care Consultation can really help increase this number. And, even though, once those caregiver stressors are alleviated, this number can go up um, as well. So, next, I'm going to talk about the program that could help caregivers who are in need of information and support and show you, give you a description of it, show you how it works using a little case scenario, and then we can talk a little bit, like present some questions and go from there. So, some of the key features of this program is that it addresses the needs of both the person with the health condition, their family and friend caregiver. So, BRI Care Consultation is unique in that way. There's protocols in place when delivering the program that help identify the needs of the caregivers and as well as the care. Whoops, that did it by itself. Hold on. So so there's an assessment that's built for each individual. Um, it's consumer driven. It's really guided by the individual or family preferences. It's an empowerment program where the care consultant is giving suggestions and advice, and the caregivers, the care recipients are really making those decisions, and the care consultant guiding them through the decisions that they're making. The program also provides ongoing support and assistance. So there's a lot of programs out there that are short term. And caregiving sometimes, in some cases, it may be short term, but in most cases, it's long term. And so it's important to have a program that could help individuals throughout their entire caregiving journey. The program also has an evidence based protocol. It allows for personalized content, and it's conveniently delivered by telephone and email by a trained care consultant. So essentially, the Benjamin Rose Institute on Aging either trains and licenses organizations throughout the country to deliver the program. And the master trainers, myself and another master trainer, Benjamin Rose, we help throughout that process. You know, everything from ongoing training and support, technical assistance, case discussions, and so forth. There's also another option where Benjamin Rose Institute on Aging can deliver the program on behalf of an organization if they don't have the capacity to themselves. So there's either option. Um, so think about that as I'm going through this. So, personal care consultant, whether it's a trained care consultant at one of the organizations that delivers the program, or if it's somebody at the Benjamin Rose Institute on Aging, helps with finding and getting connected to health and community services. So this is actually one of the top areas that families utilizing BRI Care Consultation ask about is what services are out there, what's appropriate for them, and how to get connected to them. And the care consultant helps guide them through that process. Also, prioritizing concerns using a simple step by step plan based on clients' needs. And so there's a care consultation information system that comes along with the program. So care consultants use it for documentation. It helps guide um, these the assessment, the action planning, and so forth. The care consultant records what the determined action step is, and you know what the client can do next to help alleviate some of their concerns. And the action step is populated on either an action checklist or a plan, and mailed or emailed to clients. And so they could follow along and make sure that they are taking care of the next steps. And the care consultant follows back up with them to make sure, you know, that it's going well for them. If not, you know, some alternative action steps may be assigned, and then that's the process that essentially takes place. And so the action step planning in this program is really the heart of the program. It's really the main purpose to help guide those families. Um, the care consultant will communicate not only with the primary caregiver, but other family and friends about managing difficult situations and behaviors, also staying in touch with individuals and families. So again, so adjustments can be made as situations change. And then the action plan is tweaked. So this action plan never stays static. Every time the care consultant has a conversation with the individual, the family, um, there's new action steps that are added on, and it's a working document. So it's very, if you think about traditional services and you think about care plans, those are only checked maybe once a year, maybe twice a year, and updated. This is updated each time there's a communication with the individual or family, and action steps are added. So another important piece of the program is assisting with getting other family and friends involved. And so with this key feature, it's really about, you know, encouraging and finding ways for family members that may have not traditionally been involved in helping the person in need of care and helping the primary caregiver. It's working through on how to ask for help and what they can do and having those communications. And if there's a family meeting that's necessary, the care consultant can help facilitate that family meeting as well. The care consultant is also there for clients for that emotional support. So maybe there's really no action steps as a result. Maybe it's just that the caregiver really doesn't have anyone else to lean on. Maybe there's family members that don't understand the situation, and the care consultant is really there to lend an ear and help to, work through some of those challenges and support that individual. So the key components of BRI Care Consultation are assessment, action planning, and ongoing support. So with assessment, this piece really helps families identify problems, and it's a non-traditional assessment. I'll go into what I mean about that in a little bit. Then we have the action plan to move towards solutions, and of course, ongoing support as the care situation changes. So in this program, assessment is ongoing, and it's gradually completed throughout the first 4 months, and then reassessment at least once annually. So really, when the care consultant starts the conversation with the client and begins that relationship building, it's really asking the client, tell me your story, tell me what's going on in your situation and some of your areas of concern. And that opens up, the floodgates a little bit, and the caregiver, typically as the caregiver who's communicating with the care consultant, tells them about their situation. And the care consultant may use some of the questions, which simple questions that are built in to each of the domain areas of the assessment, to clarify or maybe ask a related question. Maybe if the client is talking about anxiety, the care consultant will be inclined to ask about depression. But the assessment is not, this assessment is not a process where the care consultant asks question after question after question. So it's really a time when the care consultant just listens, pulls out different areas that the family is concerned about, and then moves to action planning and comes back to the assessment at some point during the first 4 months for the initial assessment, to complete those areas that may have not been as pressing concerns for the caregiver during those first initial communications. And then anytime that a situation changes within any one of those domain areas, so let's say it's difficult behaviors related to dementia. Maybe it wasn't a concern at the beginning, but it becomes a concern later on. Or maybe there's some fluctuation. The reassessment is recorded as situations change. And so really, we don't tell clients, the way we train care consultants is that we want this to be more of a discussion of concerns and a safety net, and not necessarily a clinical assessment. And so, again, it leads into this action planning piece where care consultants may, suggest some next steps. And again, the families would be the ones making the decisions whether or not that's what they want, what next steps they want to take. A lot of times it addresses immediate concerns first, and then once those immediate concerns are addressed, there's opportunity for long term areas of concern. Um, and then the action steps typically are related to getting better care from medical providers, linking to community services, mobilizing family support, and really offering that personalized coaching. And again, as I stated before, this is an evolving set of simple, personalized, and achievable action steps. So once action steps are accomplished, they're marked down as accomplished, and new action steps are assigned depending on what's going on in that family situation. So the third component is building upon what I just said, this ongoing support. So this is a process where the relationship is continuously built with the clients. Care consultants maintain a connection and monitor the caregiving situation. There's a minimum set of contacts that should be followed to check on the clients, especially the action step progress and the need for new action steps depending on what types of areas of concerns are identified in an ongoing way. And of course, more frequent contacts are encouraged as needed. So that's always important to relay that message. So again, this ongoing support helps respond to changes, whether it's related to the needs, whether it's related to symptoms of the illness or disability, or even the capacity of caregivers to be able to continue providing care and availability. And, in hopes that the care consultant will continue to provide them with that support so that they do have the capacity with some additional supports as well as availability. So we will go into a case scenario on how this works. So we have here a mother and daughter. So Victoria, age 47, is the daughter, and she is a primary caregiver for her mother, Margie. Um, and Victoria is also mother of three children, so quite busy with a 16-year-old, 13, and 8-year-old, and she is married. Margie, the mother, is 81, and she's a widow who lives alone. She has experienced multiple minor strokes that resulted in memory loss and speech impairment, followed by a diagnosis of vascular dementia. So, over the past 2 years, Margie's cognitive functioning has declined, and she is beginning to have increased challenges with activities of daily living and mobility. Victoria experiences anxiety and sleep issues, mainly due to concerns about her mother and her own concerns about her ability to provide adequate care for her mother and children by while managing a full time job and household. So, quite a lot going on here. This case was actually de identified for presentation purposes. This is not a photo of them, but the scenario, it is a real case that was de identified. So, how did this play out in the program? Well, the care consultant immediately recognized their concerns. There's some concerns that should be addressed immediately, and some that could be addressed later on. So the care consultant really helped this family prioritize on what was going on. So you see here that the care receiver has some issues that were addressed, such as the need to arrange services, keep her safe at home. That's the preference, right? At the time at the beginning. Her mother does experience anxiety, especially being home alone. There is coexisting medical conditions as well. Concerns about completing independent activities of daily living, of course, the memory problems and difficult behaviors, mobility and balance, nutrition, personal home safety, and social isolation. So those were the areas, and these weren't necessarily addressed during the first phone call. I believe it was just the first month, which involved 2 or 3 phone calls with the caregiver. Notice that even though the care receiver wasn't able to participate over the telephone with the care consultant, the caregiver was able to, all the assessment domains were able to be identified through reports from the caregiver. And then we have here the caregiver's assessment. So, anxiety, she's obviously with having her mother home alone. She's concerned about her capacity to provide care. There is some dyadic relationship strain as well in terms of communication is not going too well with her mother. There's some emotional physical health strain. She feels that her quality of informal support is lacking, and she's also having sleep issues. So it's not to say that other items in the assessment are not going to appear within the coming months, but these were just the ones that were identified as problems at the very beginning of the service. So this is a little snapshot of what the care consultation information system assessment section of the case record looks like. Um, there's more to it behind the scenes, but as you can see here, I just pulled out a snapshot of which areas were, identified as problems. So there's red flags next to the areas that were identified as problems. Um, you see the one, meaning that this one, it was pretty quick in terms of some care consultants like to really address things right away, which is great. But you have here areas that were addressed but are not issues. Driving was an issue because she wasn't driving, so that was already taken care of. All these other ones weren't issues, but they could become issues at a later time. And if they do, what ends up happening is the numbers grow. So if there's a two, let's say the depression surfaces later, then the red flag will appear. Then if depression um, goes away after or is manageable. I'm not going to say goes away, but is manageable. Maybe there's some meds that are prescribed. Maybe would be ideal is that maybe they're the care receiver is linked to a senior center or an adult. Actually, in this case, will be adult day program, perhaps, and that's less depressed. And so the care consultant would do another reassessment to indicate that, and the red flag will turn yellow, meaning that it's not a concern, but it was a concern previously. So, very nice in terms of having kind of this image, this little snapshot of current issues or issues that were problematic before but resolved for the time being. So, after those issues were identified, you see here this action plan. So, you also see different dates in which they were identified. So it doesn't mean that, there were first a few that were identified, then there was a subsequent call for on April 7th, and additional action steps were identified. So you have here Anthony, who I believe he's the son-in-law, to review resources around home safety and Alzheimer's. So almost immediately, another, and for other support was pulled in to this action plan, which is very nice. Typically, it doesn't happen so early on, but the husband knows, could do some of these home safety type improvements around the house. So he was assigned this action step. Jane Doe is actually the care consultant. So this one is follow up with Victoria to discuss the materials that were sent to her. And so there were some materials sent around home safety and Alzheimer's. So it's on this action plan that she will follow up. And that's great for the client to see because they know that they're not just being sent a piece of information for them to review and no one to ask questions about. A lot of times, as you all may know, there's a lot of really great information that's sent to clients, but they might not have time to read it, may not understand it. And with this program, the care consultant reviews all information that's sent to them. We have here discuss with mother the benefits of having an organized schedule of family coming into home to provide care so she could remain living independently at home. We also have, oops, in regard to resources, we also have complete home safety modifications. So that is actually, I believe, another relative who would be doing that. Um, and so this is to help Margie avoid falls and safety hazards. Um, this one here for Victoria is to attend a virtual community dementia support group every other Wednesday to kind of help her cope with her caregiving. I just for emotional support and to give her some additional ideas. Another one for Victoria is to engage in an enjoyable activity with her mother each week to help alleviate some of the strain of the relationship. Um, Delegating tasks to family members to allow more time to get ample sleep at night. Convene a meeting with husband, brother, children, and Margie's neighbor to discuss a schedule to visit Margie. And so there's a neighbor that has known her entire adult life. So so she's going to be pulled in as well. Then we have this actions checklist. The only difference is the actions checklist. As you can see, some of these have been already accomplished after follow-up, but the action checklist provides only action steps that are in process. Okay. So this program, like I said, is evidence-based, and so we've conducted many years of research on this program. So some of the proven benefits are is that improved care. Uh, Caregivers as well as care recipients reported fewer unmet needs. There was less feelings of depression, also fewer visits to ER and hospital. If anyone would like more information about this program, including a demo of what the care consultation information system looks like, any questions about licensing and embedding the program within your service organization, or contracting with Bench and Rose Institute on Aging to provide the service on your behalf, please feel free to contact me. These slides will be uploaded by Marie, and so you could um, access them and access the contact information as well. Okay.
Thank you so much, Branka. I love this program. So Branka and I actually met virtually a number of years ago when I was trying to find a caregiver service for our senior center. Funding fell through, so we didn't get to move forward with them. Branka, I'm wondering if you can say a little bit more about funding for your service, because there is a cost involved. How have other sites paid for your service initially or sustained paying for your services?
That's a very good question. So some of our sites receive federal funding from the Administration on Community Living. A couple times a year, there is a request for proposals. So what we have done is we have assisted several organizations with providing content for their for their proposals. And many have successfully received funding. And so that's been a good way to uh, provide the program initially. But one of the biggest asks from the Administration on Community Living is that the program is sustained. And so that's where Title III, D, and E come in. So the area agencies on aging typically have an application process annually. And so we encourage all of our organizations to reach out to the AAAs to make sure that they present their idea and their desire to implement an evidence-based program and apply for funding. We also have many area agencies on aging that have the program implemented, and they are actively delivering the program. And in that case, the state units on aging support their delivery of the program either through Title III funding, the Title III and D or E funding, as well as there's a couple of AAAs that have used this as an alternative to their national caregiver support program, which is great. It doesn't have, those programs do not necessarily have to be evidence-based, but with having the structure embedded and providing this enhanced model has been very promising. Other organizations have used this as an alternative to case management, which is very interesting because not everybody that receives case management needs in-depth services. And so they are offered this program as an alternative. And so there's some funding that's shifted around within organizations. We've had also a couple of organizations that there's one in particular where a foundation, which is not typically common these days, but has renewed funding for the program for about 8 years now. So that is amazing.
Wow, that
Um,
is.
and so yeah, that's not very common. But
No.
in terms of starting the program, foundation support, whether it's a local foundation, we're actually working with a foundation out in California right now that is interested in funding this program. And they have certain geographical areas that they're targeting, including California, as well as parts of Ohio and Pennsylvania. So if anybody's interested, please contact me, and I would be more than happy to share information about that. It would actually cover the licensing costs, and there is also potential for some startup funds to deliver the program in terms of staffing support. But the requirement is that the program needs to be sustained after that funding period. So as with anything, any funder will say that the program should be sustained after the funding period's over. So that's my lengthy response to that question.
Yeah, that's great. Let's see, there was another one along the same lines. Oh, if an agency is going to do this work themselves, is there any particular background they're required to have?
Yeah. So, since this is termed a coaching program, it's not an in-depth counseling program. The requirements, our recommendation for the requirements of the persons that would deliver this program is at least a bachelor's degree. Um, we also recommend that that individual have some experience with just knowledge around resources for the population that they're serving. So whether it's, some sites would be, specific to maybe dementia, other sites may be a general adult population. And so making sure that that individual is and also pretty resourceful with finding information. I will say that we are fortunate to have a lot of care consultants that are very experienced, master's level clinicians as well. And those typically, what we find is if it's embedded in a hospital system, then the requirements of that, of that larger system is that they do have a higher level of education and experience. But from our end, at least a bachelor's, and then we provide care consultants with ongoing support, not supervision, but just ongoing support, guidance on clinical issues, as well as on how to use the program.
For the action steps that you were showing us, are
Mhm.
those things that are preloaded into the system that people then just like edit the names or the person's doing the action steps, or is it something that they have to come up with during conversation?
So, this question comes up quite often, and we have toyed with the idea of having preloaded action steps, but they wouldn't be personalized then. We really want those action steps to be very specific to the individual and family. So we would, that's something that we work on in terms of ongoing training and support. We work on helping with that. We have some resources on how to design action steps, but it's open-ended and it's not pre-populated. So.
How about some of the resources that you had listed within the action steps? Like there was a resource on home safety. Is that something that your organization provides?
Yeah, so there are over 700 educational resources that are built into the Care Consultation Information System. These resources are vetted, so we actually link to other organizations that publish these resources, but the links are embedded in the Care Consultation Information System and updated about every 6 months or so to make sure they're current. The links are still active because we can't control whether an organization moves things around sometimes. But yeah, we really try to, load the information in the system. And there's also the ability for care consultants to add their own educational resources within their own care consultation information system that kind of stays housed within their own organization. So that's important too, because we all have our favorite resources that we go to, but it's pretty impressive, the list that we do have. And it's just a really great tool for care consultants.
If Ben Rose was the one doing the care consulting, are organizations able to log in and see how their clients are doing?
We currently don't not have any organizations doing that, but we would love to engage in a conversation about that to see what we can do to provide access. So we wouldn't be opposed to it. We just haven't had any organizations ask that question and have it done. Um, we are open. That's a newer part of our delivery, so it's evolving, and so we'd love to have more conversation about what type of access and what you're looking for.
And someone was asking how this care consultation service was affected during COVID because it's a pretty remote service,
Mhm.
anyways.
Yeah, so it's telephone based, and so it's one of those services that really, some I could tell you that there are a couple organizations that really shifted their services over. Their referrals jumped quite a bit because they weren't able to do their in-home services, especially when it came to home delivered meals and having some supports for them. A lot of referrals came in to care consultation that way, so it wasn't impacted during COVID, and because it's still remote. I will say, as we all know, that COVID impacted funding. And so, unfortunately, because some services shut down over the course of the past year and a half at some organizations, it impacted the program shutting down because of funding. So that was unfortunate. But in terms of having you know, being um, a program that could really be delivered during the times like these, it is excellent and then some organizations really picked up on their virtual platforms. And so that's something they haven't done in delivering BRI Care Consultation, but they started using, Zoom or mainly Zoom, I believe, to do more of a virtual communication instead of a communication.
And to clarify, the programs that shut down were the individual sites, not
Yes.
you from Ben
No,
Rose.
not
Right.
us. No, ours grew a lot. But the program, the BRI Care Consultation program that's delivered through Benjamin Rose, that grew. But as far as the individual sites across the United States, they shut down because of the results of COVID and
How
funding.
many states are you operating in right now?
So how many states? I believe nine states right now,
That's great.
and we have 34 sites. A year ago, we had 45, but
Wow.
you know, we're
But
seeing a
okay.
little bit of a dip, but we also have some growth happening because there's some recent ACL grants that got funded, and we also have, like I said, the interest from a foundation to fund new sites. So there's going to be growth in the future.
That's super exciting. I have a couple of sites in Pennsylvania that I work with that I'll make sure that they get a copy of this video and they follow up with you.
Thank you.
Uh, That looks like all the questions. Someone was asking about slides, and we are going to be sharing the slides that Branka had with you. They'll be uploaded along with this video if you need to rewatch any parts of it. Please do reach out to Branka if you have any questions, if you want to see a demo. It's really neat to see some of it in action, and I love how straightforward it looks. It's not overwhelming for any of your staff who might be taking this on. It's like she showed you on the one slide, it's this overview, and when you click on that one particular thing you're interested in talking about next, it expands a little bit more and gives you more information. I just really like how that is. And I also really like how in your assessment, it's not a clinical assessment. It's questions over a period of time. It's active listening to whatever the presenting needs might be for the caregiver. And then the final thing I love about this is that you're helping both the care recipient, the care receiver, and the caregiver at the same time, because the caregiver is doing tons and tons of support to that care recipient, and to make sure that they're educated and they're supported. It means the whole unit is just going to be stronger. And I love seeing those changes happen.
Thank you.
Branka, is there any other closing thoughts or things you wanted to share before we wrap up?
I just want to thank you, Marie, for the opportunity, and thank you for all the attendees. And I look forward to, answering further questions and showing you what the system looks like in action. So again, please feel free to contact me. And Marie, congratulations again on all that you do uh, for your company and for all the services throughout the United States. So
Thank you. All right, we'll see you all tomorrow for Dan Cohen and the Right to Music. Bye.
bye.